Welcome back to Dr. Twyman's Ask Me Anything. Every Monday night, 6 p.m. Central Time, I ask your questions all about heart attack and stroke prevention. Sometimes we throw in some quantum biology and some mitochondrial questions as well. So I've been doing this about 4 years, been a doctor for 22, and my focus is on detecting the vascular disease at the earliest stages so that I don't have to eventually meet people in the hospital. That was always my goal when I left the hospital 5 years ago. So thank you for your guys' questions that you submitted tonight. Happy to answer them, and if you have any others as we go, just fire them off in the other comments. But with that, let's get started. First question up tonight: how does the quantum world solve for insulin resistance, or does carnivore fasting work best? So I probably don't have time to go into a full-on quantum discussion tonight on it, but insulin resistance is one of the biggest things that damages the glycocalyx, the lining of the arteries. That's a gel coat that's heavily rich in carbohydrates. If you're insulin resistant and you have high oxidative stress, that damages that glycocalyx. Carnivore diet can work for some people, but if they're hyperabsorbers of sterols, they're ApoE4 carriers, they may not respond as well to those type of diets. So it's the kind of show me from Missouri motto. You got to show me that your arteries are healthy to be able to tolerate that type of diet. So you can use the Boston Heart Lab panel to assess for that. You can look at endothelial function with an endopat. You can look at central blood pressures. You can look at pulse wave velocity, and that gives you an idea if that diet's going to work for you. But probably go back into my YouTube channel. It's just drtwyman.tv. I've done some talks a little bit more on kind of my ideas of optimizing nutrition. That's one of the 4 pillars of optimal health. I'll probably have to do an update for those pretty soon, but that's probably where I talk the most on insulin resistance. What are my thoughts on uric acid and nitric oxide connection? High uric acid will inhibit endothelial nitric oxide synthase. So when you lower that enzyme, you'll lower nitric oxide. So uric acid's under a lot of genetic control. Approximately about 40% of your uric acid is controlled by your genes. It's a breakdown product of purines, which is in DNA and RNA. High fructose diets, high protein diets, high seafood diets, high alcohol diets can drive uric acid. So again, it's one of the ones where it's like some people have high uric acid and have no symptoms. Other people have high uric acid and it raises blood pressure, makes arteries stiff, potentially increases the risk of gout. So figure out if you can find a driver for the uric acid and withdraw that. But there are different supplements, medications that can lower it if it's high. Usually shoot for a uric acid level less than 6. Should we all have an ApoB level goal? If so, what is it? Great question, but it really depends on what is the health of the lining of your arteries. If you have no intimal thickening, no soft plaque, no hard plaque on carotid scans, coronary scans, femoral scans, then maybe you don't need to drive ApoB down to the 5th percentile. But for most people, shooting for about the 20th percentile is a good starting point. So an ApoB around 70 is probably ideal for most people. But it's all about the health of the arteries. I always look at that first. Then we look at what's in the blood. Then we look at the genes, what might be driving the lipoproteins. Question: has a plant-based diet been shown to be ideal for lowering ApoB? It works for some people, not necessarily ideal and not recommended for all. It depends on your maternal haplotype of your mitochondrial DNA, depends on your ApoE status, depends on where you live on this earth, what latitude, depends what season. But a heavy plant focus is fine. You just got to make sure you're getting enough protein to maintain your muscle mass. And ideally a lot of DHA for your brain and retinal health. In good hands, is a carotid ultrasound acceptable to determine vessel plaque versus a CCTA or CT coronary angiogram? So good point. You do need a trained sonographer or technician because there is some variability on ultrasound scans. If you don't have somebody who's highly trained, you'll get different results. But is it acceptable? It's a starting point. It's not a perfect correlation with what goes on in the coronary arteries and the carotid arteries. I've seen some estimates that maybe it's about 80% correlated with what goes on in your carotid is going on in your coronaries. So I have seen it in some of my patients that they've had completely normal carotid intermedial thickness scans, but they have positive calcium scores, or that they have soft plaque seen on a CT coronary angiogram. So you have 60,000 miles of blood vessels. So I always check carotids, coronaries, abdominal aorta, iliac arteries, just as starting points to see, can you find it in any of those vascular beds. What is the relationship of belly fat to cardiovascular disease? It's mostly about the inflammatory cytokines and interleukins that are released from fats. The subcutaneous fat is generally not as metabolically problematic as visceral fat. So belly fat isn't always bad for everybody. It depends on the volume, and also do you have visceral fat with it. So I do like the DEXA scan to kind of give you that idea. How much lean muscle mass do you have? How much subcutaneous fat and how much visceral fat? And, you should have at least less than 3 pounds of visceral fat, but, a pound is probably about optimal for most people. If you have a lot of visceral fat, that's where you need to work on. Does taking omega-3 increase the risk of atrial fibrillation? Do you not recommend? I always recommend people get it through diet first. I'm generally looking for an omega-6 to omega-3 ratio of 0.25, or if you flip it around, a 4-to-1 ratio, where you have no more than 4 times the amount of omega-6 than omega-3. DHA is critically important. Approximately 60% of your retina is DHA, 30% of your brain is DHA, and you have to get it through dietary means. Now, there are a whole host of studies that show that there's less arrhythmias with optimal omega check levels, and there's some studies that show that there's increased risk. But sometimes it's really dependent on what type of supplementation the person is taking. Is it EPA only? Is it DHA only? Is it a combination? It gets a little bit complicated. Also, what type of supplementation is that person taking? Brands matter in this case. If you have a poor quality brand, it may be already oxidized by the time it gets to you. If it's oxidized, it's rancid, it's going to cause inflammation in your system. And AFib, for the most part, is an oxidative stress and inflammatory condition. There's some other reasons, but if you have a lot of oxidative stress or inflammation, it's going to worsen it. So I don't routinely supplement patients with AFib with omega-3s, but if patients are concerned about it, then don't supplement. Just get it through your diet. How do different statins differ? Which one do I recommend? There's probably at least 5 different statins that are still in the market. 4 of them are generic. There are some that are water soluble. There are some that are fat soluble. I tend to use more of the water soluble ones. They may not necessarily cause as much muscle symptoms. So I particularly tend to use rosuvastatin or pravastatin. Old names used to be Crestor or Pravachol. That's just my experience. If people are really concerned about blood sugar being increased by statins, pravastatin doesn't have any data that it increases it. Probably atorvastatin, Lipitor probably is the worst actor at raising blood sugar. People have a tendency to have elevated blood sugars. Livalo or pitivastatin, good statin, is very potent. There's no generic for it, so it tends to be costly if insurance doesn't cover it. So I don't use a lot of it unless people can't tolerate the other statins, and that's the best option that's still remaining. But often I'll switch to something else before using Pitiva. Question, what are my thoughts on the Lifeline screening? It's a good starting point, but it is not deep enough to really tell you what's all going on in your cardiovascular system. They do a EKG to tell you if you're in atrial fibrillation or not. They do a carotid ultrasound that will tell you if you have severe plaque, but it does not measure your intimal thickness, so you don't get a measurement of vascular inflammation. They don't give you your arterial age. It does look if you have an abdominal aortic aneurysm. That's good. Not everybody gets that on a screening exam. People who have high blood pressure or smokers are at more risk of aortic aneurysm. And then they also do an ABI, an ankle brachial index, looking at blood pressures in your legs and your arms and doing a ratio. So it's a good starting point. And I often have patients that do them and bring them into me. But once they've gone through my comprehensive testing, there's really no reason to continue to do Lifeline screening after that point. All right, thoughts on using creatine supplements? I have stents and on Brilinta, bisoprolol, Eliquis, and statin. So can't give medical advice to say what you can and cannot take, but you have to talk to your doctors about that. But in general, creatine supplements are generally safe. It can help with muscle mass, and it is somewhat of a nootropic, helping brain ATP, or say brain levels of energy. So relatively low risk, but you have to talk to your doctors if it's okay with them to start it with those pharmaceuticals on board. What are my thoughts on bempedoic acid to lower ApoB? The person reports that they have good blood pressure, a calcium score of 0, and HDL and triglycerides good. So of that information, the first part is that your blood pressure is normal, great, calcium score is 0, low risk. Does depend a little bit on what your age is. If you're 70 years old, that's outstanding. If you're 40 years old, that's what's expected. The HDL and triglycerides, triglycerides interesting. If it's under 60, then you probably are pretty metabolically healthy. But for the most part, HDL is not really that useful to look at. You have no idea if your HDL is high, if it's actually metabolically functioning well. There's genes, SCARB being one of them, that people have very high HDLs, but it's all dysfunctional, and it's actually a pro-atherogenic finding in those people. So for the most time, I don't really look a lot at HDL until all the other risk factors have been modulated. So focus on the LDL particles and the ApoB particles first. That's just a sidebar. But bempedoic acid, that's the 4th medication that's been shown to decrease MACE, major adverse cardiovascular events. That's a pharmaceutical. So the first one was statins. Second one was ezetimibe, which is Zetia. Third was the PCSK9 inhibitors. This is Repatha, Praluent, and now there's also ilisclerin. And then the 4th agent is bempedoic acid. That was the CLEAR studies. It does lower ApoB. It lowers cholesterol production in the liver. It's working in the liver 2 steps away from where statins work. But there are no receptors outside of the liver. It's actually a prodrug, meaning the drug goes to the liver and the liver turns it on and makes it work. Not as strong as statins, so it doesn't get people to goal by itself usually. Often you're adding ezetimibe. There's a combination version called Nexlizet that has bempedoic acid plus ezetimibe in it. And it was useful for some patients if they're statin intolerant or not getting the loan to goals or the lipids to goals with just ezetimibe alone. One challenge is that it is brand name only, so if insurance doesn't cover it, it's about $500 US a month. It's sometimes very challenging for insurance companies to cover it unless you failed 2 different trials of statins and you can't get a goal with anything else. So those individuals, but cost usually dictates if you can use it or not. All right. No, we had just a glitch. All right. Is a stress test safe for an 80-plus-year-old? He had a heart attack, stents 10 years ago, and recent AFib diagnosis. We have to defer to the doctor who's recommending the stress test, but in general, stress tests are safe as long as the person is not having an active myocardial infarction. So if the heart attack was many years ago, not a concern. Otherwise, you would do a submaximal stress test after a recent stent, and probably send the person to cardiac rehab before kind of ramping up their exercise. But if somebody is doing a stress test, the first question is, what is the stress test looking for? If the person is having chest pain, shortness of breath, exercise intolerance, and you're going to put them on a treadmill seeking to recreate those symptoms, that's a good use case of a stress test. If you're just doing a routine screening stress test, it's not likely to give you an answer that you really are looking for. And if it's atrial fibrillation, depends if the AFib is controlled, but exercise is going to ramp up your sympathetic drive, and so it can worsen patients' heart rate control in AFib, but you can exercise in AFib. But often you may end up adding imaging to really have a more sensitive test of looking for ischemia, but that's the indication for the stress test. There's also reasons to do stress tests if you're looking for what's known as chronotropic competence. Sometimes patients who have really slow heart rates, then they have really fast heart rates, they go into AFib, so they're going in and out. That's what's known as tachybrady syndrome. Sometimes you'll put them on a treadmill to see what is their resting heart rate and how well they can get their heart rate up with exercise. Some people can't get their heart rate very well with exercise, and they're going to get a backup pacemaker because basically when they start having a lot more AFib, that's a sign of sinus node dysfunction. So that may be another reason. So long-winded answer about stress tests, but they usually can be safe, but you have to kind of ask the doctor who ordered the stress test why they ordered it. What are they looking for? All right. So I think I got through you guys' pre-submitted questions. Thank you. Those were some really good ones tonight. And I think a couple ones that just popped up in the comments. A lot of familiar facients. Somebody's asking, is eating protein important for the heart? Yes, your heart's a muscle, so you need protein to rebuild damaged muscle. So it's based off blood volume, not your actual scale weight, but you need at least 90 grams of protein a day to maintain the muscle mass you got. And, protein is also satiating. It's going to help with your skeletal muscle, which is responsible for your ability to metabolize glucose. It helps lower inflammation in your vascular system by having healthy skeletal muscles. So in a roundabout way, yes, protein is very important for the heart. What are the limitations with a calcium score test? How do I interpret them? So first off, the interpretation, the scan is almost automated. It's an Agatston score. So it's the density of the calcifications that gets graded by the software. And so it's an automated result. There's a radiologist that reads the report, confirm that there is no artifact, and then signs off on the report. So I interpreted the results once it's been done by the radiologist. So if your score is 0, you're low risk. Your score is over 400, that is high risk. Over 1,000, very high risk. Seen some guys recently, about 5,000 was their score, has triple vessel disease, and will ultimately require bypass surgery, and seen a score over 7,000 before. Got some stents, not bypass surgery. So the higher the calcium score, the higher the risk of severe coronary artery disease. What are the limitations of the calcium score? Well, it does not see soft plaque, and half the time people have heart attacks, it's plaque that, I'll back it up. Calcium is just a sign that plaque has occurred in your arteries and your body has formed a scar. But you can still have soft plaque in your arteries that doesn't get picked up on this test, and those soft plaques can rupture and cause a clot in the heart arteries and then cause a heart attack. So you can still miss things with just a calcium score test. They're also dependent on what age that you're doing the test. I think I said it earlier. If you're 70, 80 years old and your calcium score is 0, outstanding. Whatever you're doing is working for you. But if you're a 40-year-old man or woman and your score is 0, that's expected. So, you don't want to pat yourself on the back with a score of 0 at 40. I've seen people under 40 with scores of, well over 1,000 already. So it's not a guarantee just by age. But if your score is above 0, for the most part, there's no real reason to ever repeat the scan. You're already higher risk, start treating the risk factors that cause that plaque. But if your score is 0, likely 3 years later or so, I usually will repeat it and make sure it's still a 0. But for the most part, if you live long enough, you'll probably have a positive calcium score. It's just you want to delay that for as long as possible. Somebody says that they're thinking about buying a sauna. Any particular brand I would recommend? I have no affiliations with them, but I currently have a Relax sauna. Just a one-person sauna. My current place doesn't really have a good spot to put a bigger one. But in the past, I had a Sunlight and Impulse 3-person sauna. It was awesome. Spent almost every day in the wintertime there when I had it. It had near, mid, and far infrared. I had relatively low EMF. I have EMF meters and tested myself. So as long as you weren't resting right up against the heating panels, the EMFs are acceptable in my kind of range of things that I'm comfortable exposing myself to. Thought the benefit of the infrared outweighed any risk of the EMF. So Clear Light also has some decent ones, but it's one of the ones where it's like, the budget goes from, $1,500 and up. The bigger saunas usually are going to be between $8,000 and $12,000 or so. All right. So I think I got through all the questions so far. So I'll hang around for a few more minutes to answer more if they pop up. But while waiting for that, I have been having the videos uploaded up to my YouTube channel, which is drtwyman.tv. I bought that domain and it forwards over to the YouTube channel. I'm using a AI program to basically kind of transcribe the Ask Me Anythings, as well as kind of bullet point all the questions that are answered, so you can kind of search around for what you're looking for. I have put up some longer form videos there over the past few months. There's a video up there, how a cardiologist interprets his own labs. That's me. I'm actually going to go get my blood drawn again tomorrow after doing kind of a biohack. Did a different regimen, can see what my lipoproteins are. And once those results come back, usually takes about 2 weeks, then I'll sit down and record a new video that shows, okay, with this biohack, how well are my lipids doing? And then there's a video up there. It's a little bit older, but it's still my best video on describing the testing that I look at for vascular health. The video is called No Time to Die, because vascular disease doesn't wait for anybody, and most time people don't have symptoms until it's too late. So you gotta show me your arteries are healthy. So that No Time to Die video is still up on that YouTube channel, drtwyman.tv. Somebody's giving me a little thank you. Oh, you're very welcome. I love doing these because I get these questions often from my patients in the office. I can only see so many people one-on-one, but it's amazing with social media, the reach sometimes you can have with these videos. I went back and actually looked at it. I did a podcast with Dr. Paul Saladino, used to be known as the Carnivore MD, and that podcast has over 53,000 views the last time I looked. So there's no chance I'm ever going to see 53,000 patients one-on-one in my office, but I can at least get the information out there that, okay, these are the tests you should be thinking about, and give you some kind of road maps to think about. Okay, think about vascular health and these buckets. Is your endothelium healthy? Can your body make nitric oxide? Is your glycocalyx healthy? Second bucket, do you have a lot of oxidative stress and inflammation? If so, figure out what's driving that and pull back on that lever. And the third one, which I get a lot of questions on in the office, as well as these Ask Me Anythings, is about lipoproteins. They're important, but sometimes social media makes it a little bit too black and white that, good cholesterol, bad cholesterol, which hopefully I disavow you that there's anything such as good or bad cholesterol. There's just cholesterol. There's different lipoproteins that transport the cholesterol through the system, and that's what you're wanting to measure. That's what these Boston Heart Labs, these Cleveland Heart Lab panels actually measures, the number of particles. It's the particles that predict risk, not the cholesterol. And so cholesterol is important, and cholesterol is not bad for you. You need it. Without cholesterol, you're not alive. But you do not want cholesterol being deposited into your artery walls. It's inflammatory to the arterial walls. Think of it like a splinter. If you're getting a lot of cholesterol deposited into the artery walls, it crystallizes, and then the immune system gets activated, and the immune system starts gobbling up all the cholesterol, and then the plaques start forming. And the plaque is like an iceberg. It's growing in the walls of the arteries for many years for the most part. And only later does the tip of the iceberg break the surface and start occluding the blood flow, and then people start having symptoms. But it's the plaque that's the problem. It's not how much stenosis per se that you have is the problem. So that's why this non-invasive testing, looking at your endothelial health, looking at carotid intimal medial thickness, looking at a calcium score, looking at a CT angiogram, particularly with the Clearly analysis, really tells you, do you have issues in your arteries, hopefully 10 to 20 years before you actually show up to a cardiologist with actual symptoms. All right, and then there's a question here. Can any lipid pharmaceuticals cause supraventricular tachycardia? I have not seen that in my experience. And I've been doing this 22 years so far. Not saying it's not possible, but I have not seen it commonly. Or at all, I should say. So it's going to be interesting over the next few Mondays. I'm going to be doing some traveling. I'll be basically on the other side of the world. I think I can get the time zones right. I will put some posts up that I can kind of say, okay, yeah, this is going to work. I might have to kind of move that hour or so if the time zones don't work well enough. But I will keep on this pace Monday evenings, doing these Ask Me Anythings. I have a very detailed jet lag mitigation protocol I'm undergoing relatively soon. I'll probably share some details about that. If you're ever interested in my jet lag protocol, I have a couple of them up on my YouTube channel. Again, it's just drtwyman.tv. It's a lot about how I think about, controlling my light environments better than just wearing my glasses. This is about the only time I ever considered doing supplements to help sleep. My sleep is usually so dialed in, I can set a clock by it for the most part. But I've had the Oura Ring since 2017. I'm playing around with a couple different features with it right now, but I'm trying out a couple different sleep supplements to see does it actually improve my sleep architecture. Because as you probably know, it's not super easy to fall asleep on a plane. So going to try to figure out how to mitigate the jet lag, because I'm going to be in a plane for north of 24 hours or so. So the body's going to be really off because it hasn't touched the ground, so you're not earthing for a day, and your light environment's going to be artificial for a full day. So I'm going to have multiple pairs of blue blockers. I have actually the IO devices that actually will put blue light into your eyes at the right time. That's about the only time I'll ever do something like that on purpose, is when I'm trying to break my jet lag kind of hacks out. So I will put together a video about how it went. My goal is to make it as seamless as possible for me. I know it's not a competition with the people I'm traveling with, but I'm in competition with myself to see how easy I can make this work. And if it works for me, I'll keep sharing with you guys how it works for me. So I always appreciate your guys' time and attention for logging on. This is what I do this for. It's kind of crazy. 5 years ago, I barely knew what Instagram was. I hired some business mentors, and they're like, "You need to be on Instagram." I'm like, "For what?" There's people out there that are interested in health that you need to find out and reach. And now I have approaching 9,000 followers, which is still an amazing number. I'll never see 9,000 people one-on-one probably ever in my practice. But I hopefully can help you guys, with your health journeys. So again, appreciate your guys' time and attention, and I'll try to see you again sometime next Monday. Take care.